Good afternoon. It's a real pleasure to get to introduce Descartes. I first met Descartes when I was still voluntary faculty before I became full-time voluntary faculty. And so yeah, we were talking about differences between CMS and ECT back then. And since I've joined faculty and got to know him and to work with him on the ECT service, he's been a really incredible mentor and colleague. A little bit about Descartes' educational background. So he is a UCSF lifer. Descartes graduated from the UCSF School of Medicine, medical degree in 1993. Followed that up with psychiatry residency in 1997. And in terms of additional training in 2017, Descartes did the Diversity, Equity, and Inclusion Champion Training. Descartes is a beloved educator, teaching at many different levels in the medical school. I often see students outside his office, and every time I have elective students in ECT, they know him already, met him before. And his interests, his clinical interests include bipolar disorder, depression, ECT, medical student education, cultural psychiatry, and suicide. He gives numerous talks and presentations both in academic and community settings, and his primary roles at present include Director of Medical Student Education in the UCSF Department of Psychiatry, Director of the UCSF Bipolar Disorder Program, the Director of the ECT Service, Director of the Brain Movement and Behavior Foundational Science course for the med students, and most recently, Vice Chair for Education in the Department of Psychiatry. Welcome. Can you all hear me?
No.
Do I need this on?
Yep.
Hello?
There's a knob that says mic 1, and you should be able to turn it.
Okay. Here we go. Can we hear me now? Okay, great. Still a little bit too loud.
Okay. Can you hear me? Or should I'll just speak up?
Yeah.
I'll just speak up. Okay. Thank you so much. It's not often you get to heckle the introducer while he's doing it. I love that. And then I really appreciate mentioning all my titles, because that's what we get here at the university in lieu of salary. Thank you. Okay, so today I'm going to talk about the management of bipolar disorder. Now, 18 months ago, I spoke about the diagnosis of bipolar disorder, so this is kind of part 2. I'm going to do a little brief review in the very beginning, too, of what I went over in the first 45 minutes 18 months ago, because I think it's so much involved with the management. So there's certain key things that you need to find out. First of all, you have to diagnose the individual correctly in order to do the correct management of things. But there are certain features of the assessment that are helpful to know about as you go into the management. So when you're doing your assessment, think about this, because that will help you so much in terms of your management. So I don't have any disclosures. The learning objectives I'll go over in just a moment, actually. So this is the outline of the talk. So what I'll do is I'll start with a brief review of what we discussed in 2018, the diagnosis of bipolar disorder. Then I think that the key topics in the management of bipolar disorder, the main questions that come up are, and the focus of this will be, what is the appropriate usage of antidepressants in bipolar disorder? Because that's a common question. And then the other question is, what do you do for bipolar disorder? Now, my thesis is going to be, there are 2 types of bipolar depression, and you should keep in mind these 2 different kinds of bipolar depression. And then finally, I'll have to say a few words about making sure that even when the person's doing well, your patient's doing well, think about planning for relapse, because that's what we want to prevent. Okay, so this is kind of the outline. There are many other topics that you can go into in more detail, but I wanted to focus on those because I think those are the most common and most salient ones. I'm not going to go into the treatment of acute mania. Maybe that's something that mostly as the chief of the inpatient service could do, but I'll talk more about this issue of bipolar depression and assessment and management in kind of the long run. and there'll be a little bit of time for Q&A at the end. So first, let me go over really quickly what we discussed a couple of, almost a year and a half ago now. So reminder, I talked about the epidemiology. Is bipolar overdiagnosed? Why is it so hard to diagnose people with bipolar disorder? What are the conversion risk factors? And I'll talk about what those mean in terms of the life course method for interviewing, which is how you would interview people, and then some clinical pearls around that. And hopefully I can tie that together with the management and kind of show you why it's important that you look at this information. So bipolar disorder, is it overdiagnosed? Frequently, the answer is yes. There frequently is an overdiagnosis of bipolar disorder. In this study, the Zimmerman study, 43% of patients who said that they had bipolar disorder on the SCID did not meet criteria. 43% of them. So about half of the people who said they had bipolar disorder did not meet the SCID criteria for bipolar disorder. But bipolar disorder is still very common in the outpatient psychiatric setting, 13% in this outpatient sample. And then this is looking at other populations of people with bipolar disorder. In the general population, it's about 1%. If you took people who see primary care doctors, it's up to 10% in some populations. And in psychiatric clinics, you get a number of studies that give you around 10 to 20% of outpatient psychiatric clinics have SCID positive bipolar disorder. Now, why is it so hard to diagnose bipolar disorder? Well, one, manic episodes or hypomanic episodes are frequently explained away. So people will say, of course you'd be happy too if you discovered a cure for tuberculosis or what have you. But those are clearly, people often forget about them and explain them away. Clinicians often are not familiar with the diagnostic criteria for bipolar disorder. So needing to, this talk and our whole existence is rife with confirmation bias. So just think about that. So, and I'm trying to be aware of that myself, and I'll mention it a couple of times. But if clinicians are not familiar with bipolar disorder, they're not going to diagnose it. Relative rarity of mania in the natural course of bipolar disorder. If you look at natural histories of people with bipolar disorder, the amount of time people spend in mania or hypomanic states represents a very small percentage of their overall time, especially compared with depression. So people on average who have bipolar 1 will spend, for every 3 days of depression, will spend 1 day in either mania or hypomania. So in that population, you would just statistically be more likely to see people when they're depressed. In people with bipolar 2 disorder, the numbers are even greater, where it's more like 30 to 1, 30 days of depression for 1 day of hypomania. Now, of course, the other issue is when patients cancel appointments, sometimes they're feeling really good. They don't feel like seeing their doctor, and that may represent a mania or hypomania. So patients often don't come to see you when they're feeling good. They come to see us when they're feeling bad. So it's yet another reason why we may not see patients when they're manic or hypomanic. And then patients have poor recall of manic or hypomanic states, particularly if they develop psychotic symptoms. Recall is very difficult in that period. Several studies looking at patient recall during periods of mania or hypomania, they may not remember that they were ever manic or hypomanic. So, one study done in the 60s where they looked at, they wanted to go back and find out the natural history of bipolar disorder, and what they did was they had this idea of every patient who came in the last 5 years who was manic or hypomanic to our hospital, let's call them up and find out how they're doing now. That study never got done because half of them, when they called them up, said, "What? I was never manic." And these people were hospitalized for mania. So half of the people either don't want to say or they have forgotten that they had a manic episode. And then finally, if we don't get collateral information to confirm or refute our diagnoses, that's the other reason why. So sometimes, because people cannot remember that they were manic or hypomanic or explain it away, sometimes it's really helpful to get concrete information from family members. Conversion in bipolar disorder, mood disorders, means when a person converts from unipolar to bipolar disorder. So are there features of people who start with unipolar depression who then go on to have a mania or hypomania and therefore become bipolar? There are 4 studies that are longitudinal, long-term studies that looked at individuals and tried to tease out factors that would predict people having a manic or hypomanic episode later in life. So in this Kiskel's group had 559 patients, and they found that patients who had a lot of mood lability beforehand, so feeling like that their moods went up and down, they had trouble with interpersonal relationships, kind of the borderline-ish kind of traits. If they had a lot of those, that was predictive of later episodes of mania or hypomania. Coriel looked at his average age was a little bit older. so that they did not have as much conversion. So Goldberg had a younger age of onset, less than 25 years of age, and he followed them. Patients in his cohort who had unipolar depression were less than 25 years of age and were hospitalized. And he followed them about 15 years. Over that 15 years of follow-up, he found a 41% rate of conversion. So a lot of them went on to develop bipolar disorder. And then in Ag's Swiss study, 309 patients, these are mood disorder, he found if you followed them long enough, many of them went on to have bipolar, this one 39%. And he also noted that his population tended to be more severely ill. So if you get someone who's mildly depressed or moderately depressed who's younger, that probably doesn't count as much. These patients were often more hospitalized or more severely ill. So if you get someone who's younger, less than 25 years of age, who's been hospitalized, who's had multiple episodes, and if they've had psychotic episodes with their depression, they're more likely to later on go on to convert to bipolar disorder. So the conversion risk factors are sort of those soft, what they sometimes term as soft bipolar traits that you'll see sometimes in patients. And so then I advocated 18 months ago, like you want to do a good psychiatric history. I gave it a nickname, but it's really just a good psychiatric history, and that's called the life course method. And basically, you want to get a story, a narrative from the patient. And you want to start from the beginning of the patient's history of mood or psychiatric problems. And using life events, you kind of divide up their history into epochs. It gives you kind of constructs it so that you can have little places that you can focus on, and so that you're not just scanning this entire screen lifetime. And then you just want to go chronologically forward with each epoch with special attention to mood episodes and significant life events that can often tell if maybe and so for each mood episode, you're going to want to obtain prodromal symptoms, medications tried and their efficacy, and adherence to medications. And then finally, you want to obtain collateral. I have a 4-page little handout here if you're interested. You can just click on that to read a little bit more about that process. But that's basically my how do you get a psychiatric history if you want to diagnose for bipolar disorder? Because if you ask someone, have you ever in your life ever felt unusually elevated or happy or irritable? The yield on that question is really terrible, because if you can imagine someone asked you that question, you'd be like, yes, maybe, no, I have no idea what you're talking about. And then just a couple of clinical processes. If you already know the diagnosis, you're pretty sure this person has bipolar disorder, you still want to know some things about the patient. One would be focusing on the prodrome. You want to find out what leads up to the manic episodes in particular, because it's usually the periods that the symptoms that lead up to the period that you can make an intervention. When the person is delusional and manic, naked down Market Street, it's too late. You're not going to be able to intervene at that point. At that point, the person needs to go to the hospital. So you want to focus when you take the history. It's easy to learn all about the florid histories of mania, but once you learn enough and you're pretty sure it's a mania, you really want to focus your time and energy and attention on the prodrome. Because you want to highlight that for the patient so that when they encounter those symptoms again, that will be the time when you might be able to intervene and do something. Again, in terms of being economical, in terms of time, only obtain as much information as you need. So if they've had a lot of episodes, you might need to just get kind of the overall number at the typical course of an episode and the most recent episode, kind of by my way of trying to be more time. You have to quote the patient in your notes. When I say quote the patient, you write your notes. No, everyone's a skeptic, because if I say, oh, so John Smith had a manic episode, no one believes me. I have to say, John Smith said, during this episode, I felt like a god. I could walk on water. I could do whatever I wanted to. Then people believe you. So you have to quote the patient to be really helpful. Find the kryptonite. And what I mean by the kryptonite is, kryptonite, you guys all know Superman, right? Superman, he had kryptonite. That kind of brought him back to Earth. So when patients are manic, a lot of times they've gone through some acute hospitalization in the past that brought them back to Earth. You want to find out what meds were used at that time that helped life, that got rid of the mania. Because in an acute situation, you could, and the first time you often have to, you can search around for try different kinds of things that might work for this acute mania. But if you have an episode where the person had an acute mania and it was stopped by 20 milligrams of Zyprexa or olanzapine, for example, you want to have that in your note so that any other clinician who comes up and senses the person, they know what they were on and how much. And again, in the acute situation, and I've done this many times, you tend to go slow and work your way up. With the mania, you have to be careful, because a lot of times patients will only respond to that high dose that they were on in the past. So that's a piece of information that's very key that should go with the patient wherever they go from there. That was a hard-earned piece of information. What got rid of the mania and how much? That cost the patient a lot to get that data, so we want to make sure we're okay. And then, if possible, clinical parole will be to get collateral information. So no one has or does not have bipolar disorder until you talk to someone who knows them well and has lived with them for a long time. Frequently, psychotherapists don't know the patient that well because if they only meet with the person once a week, it's very easy to miss manias or hypomanias in that period. Okay. And then when patients come in depressed, the other key question is, when was the last manic episode? And I'll go into why that's so important. How long does this current depression last? And when was the last manic episode before that? Okay, so just remember that. Any questions about this at this point? I'm going to move on to talking about the antidepressants. This is meant to be a quick review of last time. So now let's talk about bipolar. Let's talk about antidepressants and bipolar disorder. So here's a case in 50. Anyone recognize who this is? Jean-Claude Van Damme, thank you. I like to put these pictures in it's a little trivia question for the audience. And also just bipolar disorder is quite prevalent. So, and it turns out many celebrities do seem to have or claim to have bipolar disorder. This is a 55-year-old man with bipolar disorder type 1, presents your outpatient office with depressed mood, anhedonia, low energy, sleeping 12 to 14 hours per day. He says, I think I used to be on nortriptyline, and it seemed like it really helped me a lot. So the questions are, how frequently do antidepressants trigger mania or rapid cycling? How often do they cause problems? And then, how effective are antidepressants in bipolar disorder? So now we've known about antidepressants in bipolar disorder possibly being problematic for a long time. This is a study by Ware from 1988. And this is a kind of a weird chart. You don't see graphs like this much anymore, but each line represents a single patient. And here it says off, here it says on, here it says off, here it says on, here it says off. So when the person was off the antidepressant, this is how long the cycle length was. So you can see when the patient was off antidepressants, the cycle length was this length. When you put them on an antidepressant, the duration between, the time between episodes seems to have gone down. So they start to less rapid cycling, the time seems to go down. And then when you take them off again, the time elongates from the time when they got the duration of their episode, the time between their episodes. When you put it back out again, the duration again, the cycle length again begins to narrow, meaning that people seem to churn through their episodes faster when they're on antidepressants, or at least that was the hypothesis when you say antidepressants cause rapid cycling. And remember, rapid cycling means 4 or more mood episodes in a 12-month period. Patients often get confuse that with mood lability. Mood lability is more like you're upset, you're angry, you're irritable, you're euphoric in the course of the day or a few hours. I call that mood lability. Rapid cycling to me is more like distinct mood episodes that last, that occur within a 12-month period. And then, so for example, I think if someone says they've had mood lability and give me symptoms of mood lability that last for a month, I think of that as one episode of mood lability as opposed to 60 episodes of irritability and 60 episodes of euphoria, for example. That's how it would be. Okay, so each line represents a single patient. So I'm condensing a humongous amount of information, just picking out one argument. What is the rate of antidepressant-induced switching or cycle acceleration? And so is switching clear? So when the person goes from depression to mania or hypomania. So that's called switching. So what's the rate, if you give someone an antidepressant with bipolar disorder, what's the rate of switching or causing them cycle acceleration? The answer is really not well known, but again, I'm going to cite this example of confirmation bias. I found this one article that gives a concrete answer, so I like to cite it. The answer is 12.5%. Isn't that wonderful just to get it? Now, of course, if you dig in the weeds of it, it's a much more complicated question. So this is Tondo et al. This is a meta-analysis of a lot of data. This was, actually the data comes from 35 trials of antidepressants that had an end, if you add them all up together, over 100,000 people. And the subjects actually had both major depression and bipolar disorder. The average duration of these trials was 5 months. And they do not include, because these are antidepressant trials, they do not include patients with bipolar type 1. So these are actually just for individuals with bipolar type 2. If you put them on an antidepressant, what is the rate of switching or cycle acceleration? So this is the chart from, so BPD here means bipolar disorder. So when you write your notes, by the way, for those of you residents who write BPD for borderline personality disorder, be careful because BPD also means bipolar disorder in the literature. I tend to write out borderline PD or bipolar DO, just FYI. Anyway, so in looking at this, you can see that if they had bipolar disorder and you gave them an antidepressant, the rate of switching only increased a little bit compared to without antidepressants. And then but really interestingly, if you have this population of major depression, of people with major depressive disorder, if you gave them antidepressants, their rate of switching is actually, from a percentage point, much higher. And I put this in a little kind of a box table, so you can see a little differently. So this is the same kind of numbers as the other one. But so if you give someone with bipolar disorder type 2 in this case, you give them the antidepressant, the rate of cyclic switching or cyclic acceleration increases, but only modestly, I would say. Whereas if you took this unipolar population and you give them antidepressants, their switch rate increases 5-fold. So from a percentage perspective, it's a lot different. So it does make you wonder about this population of, quote, unipolar depression. Maybe a lot of them do bipolar diagnosis. So, you know, and in my experience and a lot of the data, it's a little bit mixed about how much of a problem does antidepressants cause in bipolar disorder. And I'm going to, based on this study and some other studies, I'm going to give you my bottom line answers. It probably doesn't make people a lot worse. For some individuals, if you give me an antidepressant, they do terribly, that's clear. But many people, it's really unclear about whether they do better or worse on antidepressants. And most of the time, I feel like if you give someone with bipolar depression an antidepressant, nothing much happens. But let's look about how effective they are. So then we're just looking at whether it caused a negative problem. This is mood switch in bipolar depression. So here they took a population of people with bipolar disorder already, and they put them on different antidepressants. So randomized to bupropion, sertraline, and venlafaxine. And this study, you can see the switch rates were 10, 9, and 29% respectively. So the venlafaxine had a much higher switch rate than the other ones did. And that kind of corroborates some other studies looking at tricyclic antidepressants are more likely, or norepinephrine reuptake inhibitors are much more likely to trigger cycle acceleration or switching with people with bipolar disorder than the SSRIs. The response and remission rates were actually fairly similar in this study. But they didn't have a placebo arm, so we really don't know, did we actually help these people? We only know that compared to each other, they seem to do a little better. So just to conclude that study, venlafaxine was significantly more switching than the other antidepressants, a lot more, like 30% versus 10%. There was no placebo arm, so we really can't draw conclusions about efficacy of antidepressants in general in bipolar disorder. And the risk of switching was greater in patients with a history of rapid cycling already, so that kind of sounded sensible. So the STEP-BD had a big study, and this is probably the best study that I've come across, looking at this question. So they had patients who were already on a mood stabilizer or atypical antipsychotic, and standard antidepressants were tapered over 2 weeks and stopped. And they followed them for 6 months. This is probably the best study, and I'm just going to summarize the data in this one table here. Looking at the patients who had, so everyone was on a mood stabilizer already. They all had bipolar disorder, already on a mood stabilizer, and they were randomized to either an antidepressant or a placebo. Okay? And the antidepressant was either Paxil, paroxetine, or bupropion. And you could see in this study, the durable recovery, people who stayed well for more than a month, was actually very similar between the two groups. So adding an antidepressant did not seem to do anything. If anything, the placebo arm did slightly better, if anything. I'm not saying that they did do better, but they looked like they didn't do worse. 27% actually recovered on the placebo arm versus 23.5% who got antidepressants. The number of people who discontinued was roughly similar. The rate of switching actually was roughly similar also. Yeah. So whether they were on placebo or antidepressants, they all have bipolar disorder, by the way, so there is some baseline rate of switching. So you could argue that paroxetine and bupropion didn't really increase the rate of switching, at least in this study. But if they did have a history of an antidepressant-related switch in the past, then they did worse. So if you meet someone and they had a switch on an antidepressant in the past, then definitely don't do an antidepressant. But the bottom line is really there's no difference between placebo versus antidepressant in this study. I'm going know who this person is? Catherine Zeta-Jones? Doesn't quite look like her. So she was, so in this case vignette, you have a 30-year-old woman with bipolar disorder type 1, euthymic for 6 years. She's been on lithium carbonate 1,050 milligrams per day and fluoxetine 20 milligrams per day. Should you continue the fluoxetine or stop it? So this is another question. You have someone now who's been stable for a long time on antidepressants, or should you stop it? There's been a couple of studies looking at this, and if the person is on, I'm just going to summarize this for the time, because if the patient's been stable on antidepressants for several years, it's okay to continue. But this is for the minority of patients. Most patients you try to put on an antidepressant or have bipolar depression will not stay on it because they will not get better. Usually you end up switching or something. So it's very frequently the minority of patients who will actually do better on antidepressants than stay on antidepressants for a long period of time. And there's a study where they tried to take people off antidepressants, and they did get relapse and get worse over time when they stopped the antidepressants. So now you may say to me, but Descartes, I see a lot of patients with bipolar disorder who are on antidepressants. Why is that? Well, in my humble opinion, when patients are depressed, the patients automatically think they should be on antidepressants. And primary care providers often think that they should be on antidepressants too. I think psychiatrists are a little bit more clued into this. Now, educating patients about antidepressants, bipolar disorder, is very hard to do in an individual session. Even now, I could easily spend 90 minutes just talking about the different studies looking at antidepressants and bipolar disorder. But to do that with patients really takes a lot of time. So I would recommend thinking about a psychoed group like we have here, where we actually go through some of the information and data and talk to patients. And also you get a bunch of patients together in a room, and you can ask them, how many of you are doing well on antidepressants? You'll find that the number is actually a very small minority if anyone says that they've been doing better on antidepressants. So just to summarize, antidepressants in bipolar disorder. Antidepressants are generally not helpful in bipolar depression. Antidepressants may cause switching or rapid cycling. Tricyclics or venlafaxine more than SSRIs. If your patient is doing well, however, on antidepressants, it's okay to continue antidepressants. And for most patients with bipolar depression, in my experience anyways, stopping or starting antidepressants don't do too much. However, if your patient has mixed features or is rapid cycling, you probably, the recommendation is you definitely should stop. Any questions about that? I'm summarizing a lot of data there, and I have to say the other part that I have to be careful about is this confirmation bias. I run a bipolar disorder program. If people are doing well on antidepressants in the community, they probably don't make it to see me, right? It's only the individuals who have more trouble and who are getting more depressed and so forth. But there has been, how many of you have heard of the literature about antidepressant withdrawal or discontinuation syndromes that last a long time? There was a long article in the New Yorker, I think, by Rachel Lee, who actually interviewed me also for that article. And there's been more and more information coming out about that. So if you're ever interested in that topic, maybe next year we can antidepressant withdrawal syndrome. And some people having really some long-term withdrawal discontinuation symptoms after stopping antidepressants. That's a whole nother mind-blowing topic, because that's absolutely...
You suggest those people have bipolar?
No, this is for people on antidepressants for a long period of time. Fava has an article. I'll send it to you if you're interested. I got sent it by Amy Tyson, who's been in dialogue with me. It's been very pushing me to think more about these things, or actually doing the thinking for me, and I've just been listening to her.
That other article got a lot of press too.
The Fava article?
The what?
Which one?
The New Yorker.
Oh, the New Yorker. Yes.
Yeah, that kind of made the rounds everywhere for a while.
Now, in that, the problem with the New Yorker article, from my psychiatrist's point of view, is that she picked someone who had bipolar disorder. So once you pick someone with bipolar disorder and then you have antidepressant withdrawal syndrome, it gets much more confusing. She picked someone who had a unipolar depression and then tried to stop antidepressants that had ongoing. It would have been more powerful that's a psychiatrist's perspective, I think, but and it was a really long article too. Okay. So, case vignette C. What is this guy's name again? I can't remember. It's Elton? Brand? Russell Brand. That's what, I think he Elton Brand, but that's a basketball player. Russell Brand. Now again, these case vignettes, these are just meant to illustrate. Let's just put a picture up there. Here's another case vignette. 35-year-old male with bipolar disorder type 1 presents with depressed mood, anhedonia, low energy, sleeping 12 to 14 hours per day. Have you seen this kind of thing? Particularly, yeah, people with bipolar disorder, you can get this kind of anhedonia, low energy, depression. Now, why is it important to find out the last manic episode? And what's the difference between a spontaneous depression and a post-manic depression, also known in the literature as biphasic depression? So, I'm going to argue without much data to support me, just a little bit, that there are two kinds of depression. One is spontaneous depression. So these are people with bipolar disorder who, spontaneous depression, they're just going along their merry old way and then they have a depression. I would say that's easier to treat. So if you remember that, it's easier to treat. And then biphasic depression is a person who has a mania or hypomania and now is in a depression. That's a biphasic depression. And I like to call it a post-manic depression because it's easier to remember than it's more clear what that is. And this is harder to treat. If you're getting a biphasic depression, that's a much harder thing to treat. In my experience, if you get someone who had a psychotic mania, lasted 2 months, they were sleeping for 2 to 3 hours a night, they were hospitalized, then soon afterwards they come to you and they say, Doc, I'm really depressed. Can you give me something to help me have more energy, not be depressed? You're really hard pressed to it. If I took anyone who were only sleeping, if I made you sleep for 2 hours a night for 2 months, and you came now to say to me, I'm really exhausted, Dick, I'm really tired, I don't know if I would necessarily prescribe you a pill to make you feel better. That's my common sense, confirmation bias loaded observation. So when you get into with this idea in mind, for many patients with bipolar disorder, prevention of mania will actually lead to the absence of depressive episodes. Because if you talk to them and you get a good history, a la the life course method, you'll find out whether they've had spontaneous depressions or not, or whether most of them, and you'll find most of them or the most severe depressions are often linked to manic episodes. So if you can prevent the manic episodes, you often won't they won't have severe depressions if you get rid of the manias because they won't have a post-manic episode. So this is the one tiny study that kind of supports this topic. And looking at, in this topic, they took patients with ED, that's not erectile, that's euthymia and then depression, that's the spontaneous depressions. And they compared them to patients who had post-manic depressions. Okay? So ED patients, euthymia and then depression, if they were treated with an antidepressant, their odds of getting better was 10 to 1 versus the probability of manic switch. I don't know why they did it this way, but the odds was still good. You were more likely to get them better than to trigger a mania in these patients who had a euthymia than depression. If you added on another mood stabilizer, you didn't improve their response rates very much compared to the manic switch. Or maybe if you decrease the risk of mania. I don't know, but it seemed like in this situation, a euthymia then depression, antidepressants seemed like, oh yeah, it seems better than adding on another mood stabilizer. However, if you took the patients with the manic depression, MDs, who had the mania then depression, post-manic depression, the probability of response divided by the probability of the max, which was 0.75 to 1. So you were more likely to trigger another mania than you were to get them to respond. Okay. If you added on another mood stabilizer, it doesn't seem to help that much, by the way. This would argue for it doesn't seem to do that much adding in the situation of mania then depression. So they concluded in the study that there were two types of bipolar depression. One is spontaneous and one is biphasic, post-manic depression. Biphasic depression is associated with increased manic switch as well as decreased rate of response to either antidepressant or mood stabilizers. That would be my clinical observation as well. So if you get someone in a biphasic depression, they often don't respond as well. So in clinical practice, post-manic depressions frequently last 6 to 12 months and are often pretty resistant to treatment. But may also frequently resolve spontaneously. It may take a long time, but it may resolve spontaneously. So what you often get in the history is the person will say, well, I had a mania, and then it took me like 9 months till I got back on my feet again and went back to work. And maybe they've had a couple manic episodes. In every case, you might hear the same kind of story. It takes them 6, 9, 12 months before they get better again. And they have tried under different circumstances, different medications during that period, and it seems like maybe it was due to a change in the medication that caused them, but I would argue maybe it was just the natural history of them getting better. So you want to, when you take that history, you want to get the history of mania, how long did that last, depression, how long did that last, and then you can see if you can extrapolate and make some intelligent guesses about the curve. Now, you might ask about the STEP BD study. Looking at, in the STEP BD study I mentioned very in the beginning, a 6-month study where they put them on either antidepressants or immune stabilizers, or placebo, antidepressants or placebo. Could they divide them out between spontaneous and spontaneous depressions and biphasic depressions or post-manic depressions? And that reanalysis has been attempted, and I actually participated in that, and we were not able to find a difference in response rates in the STEP BD. So again, I actually even authored an article on the topic, and I still don't necessarily believe it, because the study wasn't necessarily designed to look for that, but we did try to find a difference, and so it may have washed out in the whole thing, but I still adhere to my own clinical observation that if you get that individual patient with a clear history of post-manic depressions, that's all the information we have at this point. Otherwise, all I can say is it doesn't matter. So, not as helpful. Okay, so what do we do about bipolar depression? I'm just going to summarize. This is the time I want to leave time for questions. It is a controversial area in psychiatry. I think you want to avoid antidepressants unless there's a clear evidence of benefit. Some individuals do seem to benefit, so I won't disagree with that, but it's the minority. You really do want to prevent mania, so you want to start mood stabilizers like lithium or divalproex. And I would mention too that in that post-manic period, people are still kind of vulnerable to shoot up into mania again. So in that acute post-manic period, mania, they're still vulnerable to cycling up again. It seems like that seems to be more of a period where people can again have another manic episode. And then, so you want to also don't rule out spontaneous recovery in patients with recent manias. So patients recently had a mania, and you know from prior history that they often recover at a certain amount of time. You can actually kind of be reassuring to patients that they're going to recover against spontaneous. And so with that, sometimes having psychotherapy bipolar disorder, that's yet another topic to be discussed, but that can be very helpful for people with bipolar depression. So when you're assessing people, just to summarize what kind of seems hopefully makes sense now, is that you want to find out what their baseline is. So how long have they been depressed? When was the last mania, and have they been rapid cycling since then? What worked for bipolar depression in the past? And of course you want to rule out substance use for alcohol or marijuana during the time of depression, because a lot of times people tend to overuse those drugs. So, and again, I just want to remind people, for many patients with bipolar disorder, if you can prevent a mania or hypomania, it will lead to an absence of depressive episodes. So that can kind of be very gratifying. Now, I will subcategorize post-manic depression even one more time into an acute phase and to a chronic phase, or spontaneous. So this would be the same if there's spontaneous depression. So if it's acute, you want to stop the antidepressants, you want to optimize mood stabilizers so they don't shoot up into another mood episode. Typically, when people are acutely depressed, they've often recently had a mania, or they were in the hospital recently, so they're on a boatload of benzodiazepines and a boatload of atypical antipsychotics, so you want to help taper that off gradually. I will often add lamotrigine in that situation. It's not an anti-manic agent, by the way, so just by adding lamotrigine, you're not preventing the risk of them having another mania, and the clock kind of resets again. And then I sometimes tell patients, I like to say nothing works, but I mean that in a good way. If you do nothing, it actually works sometimes. Like people will often get better. So, and I do wonder, you hear a lot of patients who, they've been on, they were depressed, had bipolar depression, post-manic depression, they get put on lamotrigine and they start to feel better. I would, the cynic in me would argue lamotrigine, it takes you 2 months to taper it up to speed, right? 2 months later, if you gave someone 2 months of something, they will get better over time if they have bipolar depression, right? Because they're just, the natural history is oftentimes to get better. So now, if it's been longer than 6 months, then I will try to or if it's been longer than their prior natural history would suggest, then I would suggest trying to be a little bit more aggressive. So things like quetiapine, aripiprazole, or lorazepam all have controlled studies looking at them for depression. They do seem to help. Usually the response rates are in like the 60% range versus placebo, where the response rates will be 30 to 40%. So again, it helps, but some of these have side effects and so forth. So sometimes doing less is more. I like to make sure thyroid is supplemented appropriately, and even if it's not, sometimes a cytomel augmentation strategy can be very helpful. The nice thing about it only takes a couple weeks to find out whether it works or not. For those of you who are not familiar with cytomel, it's triiodothyroxine. Light therapy can be helpful for patients. That's another talk. If you're interested in that topic, I recommend www.cet.org. ECT also works in that situation. If it's more chronic, if it's been a long time. Typically, when we're in our ECT service, for most of you not familiar with this, typically patients with bipolar disorder are typically depressed for maybe a year or more. Well, most patients in the service are depressed for a year or more, so we're out of this acute phase. I think the question is still out about transcranial magnetic stimulation, about this, whether this kind of same issue applies. Same with ketamine, and then there's some studies looking at modafinil that seems to be somewhat helpful with people with bipolar depression. So I think let me just wind up here just saying that if you had to remember one thing in this little section I'm talking about, is like spontaneous depressions are easier to treat, just treat them like regular depressions. But if they're biphasic or post-manic depressions, they're harder to treat. And you might want to think about taking it easy and not being too aggressive, actually. And for many patients with bipolar disorder, prevention of mania will actually lead to absence of depressive episodes. So get this nice little extra benefit. And if you can engage the patient in understanding that sequence, mania then depression, that can be really helpful, because that really makes them adherent or engage in the treatment that much more. Because otherwise, many patients may not be that averse to having manias or hypomanias in and of themselves, but if they can begin to link that they are linked with these terrible depressions, then they are very motivated to get manic or hypomanic or risk mania or hypomania. I would say actually clinicians in general, just FYI, are often thinking that patients like to be manic or hypomania. That, I think, is the minority, in my experience, the minority of things that patients don't like about mood stabilizers, for example. Patients themselves, actually in certain surveys, don't actually list as reasons why they go off their meds because they're missing their highs. The reasons why they go off their meds is because they don't like being on, they don't like having side effects from medications. The second common reason is there's a philosophical issue of who likes to have their moods controlled by a pill. That's the other reason why people go off their meds. And they're not sure that they have bipolar disorder. So again, a bipolar group therapy can help engage people in consolidating that. So let me just say a few words about maintenance treatment or planning for relapse. All too often when we're working with patients, we're just so relieved that they're not in an acute mood episode, we just kind of forget about this other thing that it could happen again. And unfortunately, lightning often strikes in the same place twice. So reminding patients that it could happen again, going over the prodrome, helping alert them if they have a prodrome, what are you going to do, what kinds of things. I really like the idea that you've got to get them started on something that prevents a mania first, lithium or divalproics. They tend to be pretty well tolerated, and if they're not well tolerated, you got to get them on something that is tolerated, so they're going to stay on it. But still plan for a relapse. So a lot of times you're tapering down the lithium to a lower point than that would prevent all manias, so they still might get some manias or be at risk for mania, but then you give them a PRN. So that's the atypical antipsychotic that I also sometimes call the kryptonite for the person, so that they have a little bit more control, and they're not on such a high dose of lithium or divalproics that they find their quality of life really suffers. So, for example, if a person's not on lithium or divalproics, they might have, 100% chance of getting manic in a year, say, or 2 years. Whereas if you put them on lithium or divalproics, even if it's not at the highest level that you would like, they still might have little breakthrough kinds of symptoms. You might be able to nip those in the bud. And so that takes a little bit of trial and error and courage on your part to work with the patient to do that. But if they start letting them control that, hey, if they're starting to get having some of those prodromal symptoms, that they can take an atypical antipsychotic that they have in their cupboard at home, so they can take it in their home. And oftentimes they'll tell, and in the group psychotherapy, again, this is where it's the most useful. You often have to coach patients, if you just take it for one night, that may not be enough. If you needed Zyprexa or olanzapine 20 milligrams in the past, you might be able to get away with 5 milligrams since your symptoms are not so bad, since you're just mildly elevated. You can't, but you might need it for more than a night. Some people might need it for like a few days or a weekend to really nip it in the bud, as it were. And so to help coach patients through that helps out peers and so forth. So again, so group psychotherapy I think are really helpful. Again, this is another topic, but there's actually several different kinds of evidence-based psychotherapies for bipolar disorder that, when I say evidence-based, have been shown to prevent relapse, prevent hospitalizations. That's psychoeducation, cognitive behavioral therapy, interpersonal social rhythm therapy, family focus therapy. Again, a talk for another day, but very interesting. We have a psychoeducational group, and the group, the reason why we like psychoeducation here is because you can treat a lot of patients at once and kind of get these main ideas across folks. And again, planning for a manic relapse. Remember the kryptonite, PRN, and psychotics. The other part of all these kinds of therapies are a mood medication diary, and kind of a lifestyle and attitude change for patients to realize, hey, I have a disorder, I kind of take care of it. I probably do need to take care of myself more than my peers do now. I can't stay out till 2 in the morning if my peers can. I have to take it easy, but that's part of just getting better. I recommend a lot of books. There's a bunch of different books. My favorite books is this one, Marbles Now by Ellen Forney. It's a graphic novel, so it's something fun for people to read, and I could read it in a couple of hours. And it also helps these books, what they really do, I think, is overcome stigma, for patients. Like having bipolar disorder, it's not a death sentence. It doesn't mean you'll be homeless living on the streets. A lot of very successful people have bipolar disorder. But, I was thinking about all those famous people that I just showed you. They got a lot of money and they can afford, I'm sure, like all the psychiatry that they want. So given that our patient population doesn't have as much money, they can still get by with some of these other things. And I would wonder if having all that money and access to drugs and stuff like that might put you more at risk. So let me just stop here. And because I talked about antidepressants, I talked about reviewing diagnosis of bipolar disorder, talked about antidepressants. They kind of are maybe useful, but be careful. Generally, I try to avoid them. And then that there are 2 different kinds of bipolar disorder. The euthymic, spontaneous bipolar, euthymic depression, euthymia then depression, that's the spontaneous. And then there's the mania then depression, post-manic depressions, or biphasic depressions. So let me stop here. So a few minutes for questions.
Descartes, where do you find lamotrigine most useful?
Lamotrigine is kind of useful for the patient who has a lot of different kinds of, or milder depressive symptoms. The thing with lamotrigine, it really doesn't hurt that much, so I kind of have a lot of people on lamotrigine.
The patients like it, and very few of them have problems with it.
Very well tolerated. Amy Tyson talked to me about her patients less than 25 years of age. She's more reluctant to start SSRIs now who have depressive symptoms, and if they have a lot of the conversion risk factors, maybe she'll even just start them on lamotrigine before getting into a lot of SSRIs. I think it's probably a little bit unrealistic for, at this point in our culture, for everyone just to go to lamotrigine without SSRIs. And so I think everyone probably will get a trial of SSRIs just to be realistic in our culture. But if you've had 1 or 2 antidepressants and the person hasn't done well, I would really ask people not to keep blasting away with antidepressants, but maybe thinking about.
I use it a lot. So.
Yeah.
Descartes, for the prodrome that you described, and maybe the importance of relying on the prodromal symptoms to stop the mania early, I'm wondering what sort of symptoms you've elicited from patients that tend to be like relatively sensitive and easier for them and or their people around them to notice. If there's anything in particular you recommend patients look out for.
I would say this. I would say yes, there's some unique things, but if the patient has other manic symptoms later and doesn't have the same ones they had before, oftentimes it still is a mania or hypomania. And so many times I've gotten burned with the person said, well, I'm not like really spiritual now, so I don't think it's a mania. But in fact, they were, self-esteem was through the roof and they were doing other things. So not to hone in too much on it, but it is worth it to do. But things that are more sensitive would be things like spiritual awakenings, which, I hate to be like too much of an atheist to patients who are very spiritual, but family members can be really helpful in this regard because then they can give you a cultural context of what is spiritual and what is getting manic spiritual kind of thing. Ideas of reference are very common too, so patients who begin to see significance in numbers or certain words will pop out of them. Those to my mind seem relatively specific for manias or hyper. They're quasi-psychotic spiritual type of things. But it is really, there are a lot of non-specific symptoms that go into mania or into our psychiatric syndromes in general, but specifically mania can be very heterogeneous.
To go along with that, I'm wondering how much utility or emphasis you've placed on symptom tracking or kind of biometric tracking, I don't know, food intake, weight, sleep hours, how helpful that tends to be.
I have a tough time getting patients to do the mood tracking, to be quite honest. So I find it better just to, some of them will, who go to the group, because everyone else is kind of doing it, and you review a bunch of different mood tracking apps, they get to pick the one they want. I find in my one-to-one sessions, I'm just too busy, I don't have the time, I always feel like I should spend more time with the person and I forgot to mention something. So I think it's very hard to do one-on-one the mood tracking. It's better to do it, assign it to a group setting just to relieve yourself of some pressure, because I find most clinicians probably have the same trouble that I do. And then I think what happens is in the first month or two, people are doing a good job of tracking, but over time, the people are feeling fine. If you're doing a job well, they're doing fine. So after a few months, they kind of get bored of doing it. If once you master a recipe, you don't keep reading the recipe, you kind of just make the food and just go on. So what I do is I try to get them to do it in the beginning and just say, hey, I realize that over time, once you've mastered this, it'll be much easier, and actually it'll be very boring for you because you'll have the same entry every time. Once that happens, you don't have to keep doing it, but once you start noticing certain things happening again, then you can restart, and once you've learned the skills, you can redo the skills when hotspots occur. New birth of a baby, or you get a new job, or you start to feel differently, then patients will then start to mood chart, which I think makes a lot of sense just in terms of efficiency.
I was wondering, in that slide you showed about mood switch and bipolar depression, there was a huge number of dropouts, right? It was 30%, 40%. Mm-hmm. Was the response rate then an intent to treat? Because those were, did that take into account the dropout?
Let's see. Do you remember which slide it is?
It was titled Mood Switch and Bipolar Depression. I was wondering if...
it doesn't matter. I'm not going to.
Yeah, it's.
I can't remember.
Okay, I'm
I have to.
curious. It seemed like a very high response rate, so I was wondering if they didn't take into account those 30% that dropped out.
I don't know the answer to that.
One of your questions on one of your last slides, you used the term bipolar spectrum as favored use of antidepressants, mood stabilizers rather than antidepressants. Could you define what you mean by that, bipolar spectrum?
So bipolar spectrum would include, so when people talk about bipolar spectrum, some of they've come up with a bipolar spectrum index too, but basically it is things like the conversion risk factors. So if the person has a lot of mood lability, they're younger onset, they've had more severe depressive episodes, they've had psychotic depressive episodes, they've had recurrent episodes, so in some studies the person's had more than 6 episodes of depression or 3 episodes, they're more likely to have an episode of mania. So those are the soft signs of bipolar disorder. Family history of bipolar disorder would be another kind of bipolar spectrum. And then I would call it aberrant reactions to antidepressants. Some would say if antidepressants don't work, then it would be considered a soft sign of bipolar disorder. I think and maybe this is just for my own personal consumption, I tend not to think of it as bipolar disorder, because then it begs the question of, well, what is bipolar disorder if you're calling it bipolar spectrum? I call it mood disorders that respond better than mood stabilizers, maybe, or mood disorders that don't respond to antidepressants that we can think about. But that's too long a name. It's easy to say bipolar spectrum.
When you use lamotrigine, do you follow the levels at all?
I don't follow levels. I just give the person lamotrigine, get up to 300 milligrams. And then, by the way, the reason why they give 300 milligrams is because they tried 200, 400 and didn't see a difference. Well, let's shoot for the middle. And in fact, lamotrigine doesn't even have, I have a whole bunch of slides on this, doesn't have an FDA indication for bipolar depression. So they've actually tried a couple of studies where they tried lamotrigine for bipolar, and it didn't really work. What it does do is it prevents people who are manic, who have bipolar disorder from falling into a depression, but doesn't really help them once they're in a depression. So interesting. It's another interesting topic about confirmation bias. Why do we use lamotrigine as much as we do? Well, mostly it doesn't have side effects, but it's not as effective as I think we'd like to think it is. We have confirmation bias on this. If we do what the person seems to get better, we say, okay, lamotrigine is good. Okay.
Well, we're at the top of the hour.
Yes.
Thank you.